This program is brought to you by Emory University.
Morning, everyone. It's a great pleasure for me to introduce today's speaker, George Mensah, whom many of us know already because he's been a friend of Emory for many, many years and has attended a lot of these meetings and many others, and is also going to be there at Escape this year. George is originally from Ghana, but he grew up here and went to Harvard and then to WashU for training, and then has had lots of different appointments, but he's been a clinical leader for a decade or more at MCG and Vanderbilt, where he did some research as well as lead the clinical programs. I hope I'm getting this right, George. And then went to the CDC, after which I think he had a short stint at Pepsi, where he tried to reform them in many ways. And after great success there, he went to the NIH, where he now leads programs, but works directly with the director, who's Gary Gibbons, to move translation of research into the clinical arena, sort of implementation, translational research, which he's going to talk about with us today. So welcome, George, and thank you very much.
Thank you very much, Arshad. I mean, you were in a role there until you mentioned that other company it's not supposed to be mentioned in Atlanta. So I understand this is being recorded, so please forgive me. Usually I like to walk around a little bit, but I've been advised that it's better to stay here so everyone can hear me. So thank you very much for inviting me. I should formally thank Dr. Taylor and Dr. Larakis for the invitation, and certainly thank all of you so early in the morning to be here. And it's a really delight for me to join you. Here's my disclosure statement. I don't have any conflicts to disclose. And importantly, even though my trip here is supported by the federal government, nothing I say here should be construed as an official NIH policy or HHS policy. What I would like to do is cover three main objectives. Just give a broad spectrum of the remarkable advances that we've achieved over the last 70 years. And then right after that, really plead with you that we have some challenges. And this is the time to really think about the challenges, how we help translate these remarkable advances into real individual and population health impact. And then highlight the real importance of research and research training and the innovative ways in which we can help accelerate this process. And I'll try to do that by touching very briefly on the history of the National Heart, Lung, and Blood Institute, address the spectrum of landmark discoveries that have really made a huge difference. The intent is not to go into detail on any of them, but just remind all of us and give a flavor of it. In fact, a lot of it has been done right here at Emory, and so you're all familiar with it. But I think for the record, it's important to mention what some of these have been and talk about the real challenges we have in translating these discoveries into practice, and then the need for real implementation research, how we answer some of those thorny questions about moving science and discovery to make sure that really benefits the people that we serve. Now, before I start, though, I have to let you know how thrilled I am and how welcome I've been made to feel. Emory played a big part of my decision to come to Atlanta and to take the position at CDC. In fact, it was David Harrison and Wayne Alexander who were among the very first to welcome me when I came here. And very fortunately, I've had the real benefit and the wisdom in terms of mentoring over nearly 20 years from faculty here, Doug Morris, Baron Williams, and my colleagues, Larry Sperling and Arshad, and some even newer friends. And if I went on, I could go on for another 5 minutes. of all the individuals, many of who are here today, who've made a big difference. So a personal thank you to colleagues at Emory. Now, just to show how welcome I was made to feel, even with the bad weather last night, people drove in from the flood and had a wonderful dinner. So again, a real personal thank you, and I'm just delighted to be here. Now, from the Institute's perspective, I have to recognize the crucial role that also this faculty and the Department of Medicine have played in our whole research enterprise, but also the clinical enterprise and actually modernizing the care of cardiology. The giants of the past labeled here, but certainly we have giants today with us, and I'm showing this because just about a week or so ago, we had the opportunity to have Dr. Wenger come give one of the distinguished 70-year anniversary lectures and the remarkable role that she and colleagues here at Emory have played in advancing cardiovascular health in women. So again, a big thank you to her and to Emory for that. And finally, it's very hard to find a group of federal government employees who look so happy, right, with all the smiles. But we are indeed happy, and I bring very special greetings from the Institute leadership, and again, to thank you for the remarkable research that you do, because it's the research you do that really makes us look good. I should mention that it all goes back to 1948. This is when President Truman signed the National Heart Act, which established the National Heart Institute, and at the same time also helped create the Framingham Heart Study. So we celebrated the 70th anniversary of both. And I showed this slide, and I wanted to mention that the morning before the president signed the act, there was an editorial in the New York Times. And in that editorial, there was a comment made that said, $15 million is all that is needed to do for heart disease what is being done for cancer and other diseases. Remember, at that time, there was a National Cancer Institute, but there was no Heart Institute. And made a very strong case, in fact, something that would sound quite familiar. It said, if Congress provides the money before it adjourns, 9 million people who know that they have heart trouble could have the opportunity to live a better life. So there's always been a clear link between support for research, research advances, and the quality of life that people live. And so when I talk about the challenges we have, that is the real essence of that challenge. Now, President Truman signed the bill. We didn't get $15 million. We got $3 million. But compared to today, our institute has $3 billion, and that's real money. So when I talk about challenges and where we need you and your innovation to apply for some of that money to help us really translate research into practice, we really mean it. For the next series of slides, I'll very quickly go through some of the remarkable advances that have really made a difference. And of course, we have to begin with the Framingham Heart Study. Even the concept of a cardiovascular risk factor would not have existed without the National Heart Act and the work done at the Framingham Heart Study. Here showing the original director for the study, and Bill Cannell, a subsequent director all the way from the 60s to the 90s. But in the middle is the most important concept, that when the three key risk factors, blood pressure, body weight, and cholesterol, when they are ideal, the likelihood of having an event in terms of coronary heart disease was very, very low. On the other hand, when two or more of these were present, clearly a very high risk. We've known this now for 70 years. And it's quite remarkable to see where we are when it comes to the population's health and the burden of risk factors. It wasn't just the clinical observational studies, because over the next 20 to 30 years, some remarkable advances were done, particularly understanding the blood vessel wall and the contributions not just to coronary disease, but also to hypertension and other vascular complications. The importance of prevention and lifestyle, even back then, was highly mentioned, the Institute had a crucial role in the National High Blood Pressure Education Program, the Cholesterol Education Program, and several other programs that helped raise the awareness of the population in terms of the findings from the Framingham Heart Study and the importance of risk factors. This is a classic slide that I'm sure you all know about, but some of the very early work, which eventually led to the Nobel that Frischgart got, but this is work from Lederman and Wayne Alexander showing the paradoxical vasoconstriction that you see in the presence of diseased coronary vessels. Here, control levels of vessel diameter, but in the presence of acetylcholine, significant vasoconstriction, even more so in the diseased vessel. This is the pre-disease segment. Very, very different from what you see in the normal vessel where you see vasodilation. The importance of oxidative stress, the importance of endothelial function, these were the very beginnings and work that has been continued here at Emory. And I'm showing you the images, the original images in 30 years ago. They were very straightforward, black and white, just give the facts and move on. But really very important concept in our development of vascular biology and improvement in coronary atherosclerosis. It wasn't just atherogenesis. So hypertension and the other risk factors, important advances, heart failure, both atrial and ventricular arrhythmias, and valvular heart disease, all of cardiovascular disease. In fact, if you compare to the advances that were being made in cancer, huge, huge difference and huge and dramatic declines in coronary mortality compared to 1968 when we had the highest mortality, almost a 70% reduction. At the time when we also had the development of very safe and very effective drugs, devices, and now the biologics and improved diagnostics. So all the way from animal lab and animal research to even zebrafish research and research at the population level. Collectively, they've helped really make a huge difference. This is a graph that puts into perspective the dramatic decline all the way from the highs of around 1968 and the fall since then. And I just wanted to use this to highlight the role that coronary interventions have also played in terms of longevity and improving quality of life, and the work that Andreas Grunzig did and perfected it here at Emory, working collectively with Spencer King and the interventional cardiologists here. These have made a huge difference, all the way to present-day work in genome-wide sequencing with a very deep sequencing that beginning to look at new targets for development of drugs, development and improvement of device therapy for cardiovascular diseases. This is all really, really good news. Now, I should mention that Larry Sperling introduced me to the Framingham, not Framingham, but to the FH Foundation and familial hypercholesterolemia. So I want to use it as an example of two things. One, the dramatic and remarkable discoveries in basic science, all the way to drug development, all the way to improved management of patients, but also even there, the second important concept of the challenges we have in translating these discoveries into population impact. Picture of Joe Goldstein and Michael Brown on the day they got their Nobel Prize. We're certainly very proud of this. And picture of the 10-year-old girl in whom the work on homozygous severe elevation in plasma LDL, that work was done, leading to receptor biology, development of statins. And in fact, as we know today, other work has shown that statins are powerful not just for the severe LDL elevations, but even in individuals with normal cholesterol levels, normal LDL levels, when they have acute myocardial infarction or have evidence of severe atherosclerosis. Important to keep in mind what the research has shown, what we know, and again, the challenges that we face when I get to that. For a long time, the lipid hypothesis and the discoveries really led our scientific work, but there's really excitement as to other avenues that may provide new ways and new targets for drug development. This is the work showing that CD47 blocking antibodies actually can restore active phagocytosis and prevent atherosclerosis. Of course, CD47 also have immunologic functions, and so by blocking it, the real concern is also lowering immunity. And the recent findings in the TNF receptor-associated factors, that shows that you can selectively improve the phagocytosis, clearing of dead cells, increasing the likelihood of developing stable plaque without impairing immunologic function. So definitely a significant step beyond our traditional thinking of the lipid hypothesis and atherogenesis. I think this is definitely an exciting avenue for cardiovascular research. So the TRAF-STOP treatments suggest that you can selectively improve phagocytosis, enterocytosis, improvement of plaque, and stabilization of plaque without significant impairment of the immune functions. Similar story here with the CD34 work here at Emory. I shared Koyomi showing that, in fact, when you have higher concentrations in cell therapy, you can significantly reduce major adverse cardiovascular events. This is a control group compared to the treatment group. All patients who received cell treatment, not a big difference, in fact, no difference at all, but clearly a dose-dependent improvement. And again, these are early. I was trying to get some tips from him last night as to where that is leading. But again, another example of the remarkable advances and even more work that we need to do to make continued progress. Another area of excitement in terms of not just what we funded, but the research that is current, certainly the knowledge that the presence of clonal hematopoiesis can be another novel approach to addressing atherogenesis. In this example from Jaiswal's group, showing that the presence of clonal hematopoiesis is associated with almost a doubling of the risk for coronary heart disease. And if you look specifically at early onset myocardial infarction, almost a fourfold increase. So the potential to follow this avenue of thinking, to think of new ways in which we can prevent early atherogenesis, we can prevent early myocardial infarction, can lead to millions of lives saved. We're certainly very, very proud of this work. I've showed you many examples from hypertension, from ordinary risk factors to atherogenesis, but we've also learned a lot about the primary and underlying basis for cardiomyopathy and the progression to heart failure, whether you looked at the acquired forms or mixed forms, or even the genetic forms in which there's substantial work in genomics being done now. Right at NHLBI, this is probably the largest funded work looking at whole genome sequencing. We've done now about 120,000 whole genome sequence. You see the diversity of conditions from asthma and COPD to hypertension to atherosclerosis and mixed phenotype settings. But we are building this and making that data widely available to stimulate research as we move towards precision medicine and finding ways to precisely, in a deeply phenotyped and genotyped way, characterize the conditions that individuals have so we can target specific treatment. Again, excitement around the discoveries that are being made. Now, this cartoon I found very interesting and actually very true. I think they were trying to describe the prototype Emory investigator. And as you see what these rabbits are saying, so the Emory investigator, they're harmless when they are alone, but get a bunch of them together with a research grant and watch out. And in fact, that's what we hope, that we continue to get the support to make research grants available. And part of my mission here is to encourage you to think about the challenges that I would address and think of ways in which you can send us your best applications, and we will do our best to fund as many of them as possible. Most of the work that I've shared with you have been in an extramural setting, where we provide funding to outside investigators to do the research, and that's what I've talked about, and that's what makes us very proud. But we also have an intramural program. That's the program from which our shed left and came here. And I mention it to say that particularly for the fellows who may not know about the intramural program, it would be worth discovering what it is, because it's another unique avenue, particularly if you're interested in interventional cardiology, diagnostic imaging, but almost any aspect of cardiovascular research. Staying here and doing the work is great. Maybe getting some experience there with our intramural program is also another opportunity that should be explored. I wanted to show this is from TCT Live last year with colleagues at Henry Ford, and I believe this may be public knowledge that Adam Greenbaum is going to be joining you. But this is work that Vasilis and Adam, working with John Lederman at NHLBI, have done. Some really remarkable, very innovative approaches to dealing with some of the intravascular and transcatheter challenges. Whether you look at the basilica procedure, and I'm assuming you all are familiar with this, this is the intentional laceration of the aortic cuffs to prevent coronary artery obstruction when you're doing transcatheter aortic valve replacement. And one that I even find even more exciting is the lampoon procedure, where it's also intentional laceration of the anterior mitral leaflet so that you prevent life-threatening, sometimes fatal left ventricular outflow tract obstruction. The images don't do real justice to the complexity and the innovation in this, and I'll encourage you to watch the video. There's a video that accompanies this diagram, but in this setting, you see the transcatheter valve behind the anterior leaflet with when it's displaced, can cause severe LV outflow tract obstruction and lead to death. But what is done is the intentional laceration creates an opening that completely relieves the obstruction and can allow patients who are not candidates for transcatheter procedures to safely have them. So these are all really very novel and very exciting. All of this has been done. In fact, I think Vasilis was the person who thought about it, and in partnership with Robert Lederman got this work done. And I understand there's an MOU between NIH and Emory. And again, when I speak with the fellows this afternoon, I will tell you a little bit more about it and how you can take advantage of both the extramural program as well as the intramural cardiovascular program. Now, for the rest of the time, I want to say that the spectrum of examples I've shared with you is good reason to be very proud of the work that you've done. The work Emory investigators and investigators around the country. Now, after saying that, I would also say that we have a problem. We have some major challenges, and I hope that you would think about how we can work together to address this in serving the population under our care, and especially you may have some ideas as to how NIH, and in particular my institute, can begin to address these challenges. The work of Ballas and Boren, after extensive literature assessment, found that in general, it takes about 17 years for only a fraction, 14%, of scientific discoveries to become routine day-to-day care. That was work done around 2000. But similarly, Beth McGlynn showed that on average, most Americans only get half of the recommended prevention and treatment evidence-based guidelines that we know of. Half of the people get it half the time. That's a huge challenge. So we can be very proud of all the research and the basic science and the remarkable, rigorous clinical trials we're doing, but if only half the people are benefiting from it, we have to find ways to make that whole. Now, you would think we've known about this for more 15, 18 years, and we've taken steps to address this, so you would think we've made progress. But actually, work published in the last 2 years shows that in spite of nearly 10 to 15 years of finding ways to solve this challenge, still only about half of recommended preventive, acute, and long-term quality healthcare recommendations undertaken in this country. And there are substantial deficits that continue to pose real serious hazards to the health of the American public. This is work from Levine and colleagues. In the left panel, we're looking at trends in recommended care, evidence-based care, based on the remarkable research discoveries that we just talked about. If you look at recommended diagnostic and preventive testing, we are below 80%. Almost everything you look at, recommended diabetes care or recommended cancer screening. So it's not just cardiovascular disease, it's pulmonary, it's cancer. Wherever you look, we are way below 80%. And in fact, in some settings, if you look at the recommended evidence-based medical treatments in rigorously assessed outpatient care, we're doing less than 40%. It should be 80, 90%. And so what are the challenges? And it's not just simply patients don't take the drugs, or simply patients don't have access, or simply there are disparities. There are important behavioral, social, psychological, but also economic and multiple other causes, and there are scientific challenges that we can play roles in forming the right partnerships to begin to do the research to answer these questions. And the right panel here, if you look at trends in avoiding inappropriate care, class 3 recommendations in cardiovascular guidelines, it's around 90%. But of course, it should be 100%. This is evidence-based suggestions saying something shouldn't be done. There's really no reason why it should be done. Inappropriate medical treatments, 90% avoided. If you look at inappropriate cancer screening, so we have remarkable scientific discoveries. We have a challenge in translating the discoveries into routine day-to-day care. You can ask the question in the area that is most relevant to our practice. What is the cardiovascular health of Americans today? How heart healthy is our nation? Now, one index you can use to measure that is the American Heart Association Life Simple 7, where the 7 major risk factors are addressed here. When they are all normal, you have ideal heart health. So how heart healthy are we? If you look at the proportion of Americans who have ideal health, only about 15% of African Americans do, and 25% of Hispanics. At the time this was assessed, the highest heart healthy proportion was in whites. That's the good news, 40%. The bad news is, ever since that time, that proportion has been coming down. So even the group that had the best heart health is getting worse, not getting better. That's the bad news. And in fact, when you look at the graphs, one of the first visual impression you get, here we're looking at the participants who have optimal cardiovascular health, and we're looking at it by race and ethnicity. So these are non-Hispanic whites, these are non-Hispanic blacks, and you see that the gap has narrowed. Now, in general, when disparities improve, it's a good thing. But here, the reason the disparities have improved is because whites are getting worse. That's not how we want to eliminate disparities. We want to eliminate disparities by everyone doing better and the group that has the worst index doing much better so that the gap narrows. I think this is a challenge that we as cardiovascular professionals, as clinicians, as researchers, need to find a way to solve. It is not acceptable. I give you another quick example. I showed the earlier picture of Goldstein and Brown getting the Nobel Prize for work that's now led to also safe, powerful statins available for really saving lives. Screening for cholesterol and awareness of cholesterol is actually excellent. So on the left chart is people who have had their cholesterol checked within the last 5 years. And if you look at FH patients who have the highest risk and the highest levels of cholesterol, more than 90% of them have had their cholesterol checked within the last 5 years. That's great news. Other patients who have high elevations of cholesterol, 80 to 90% checked. In the general population, not as well, 70%. But even that, we know we can do better, but that's not too bad. So awareness is great. These are individuals who've been told that they've have elevated cholesterol and they need to do something about it. For FH, around 90%, 80 to 90%. In the individuals with severe dyslipidemia, also high, about 80 to 90%. Not so great. But in general, people are aware, they're getting screened, they're getting tested. So we ask the question, how many of them are getting statins? Because now you have widely available generic statins, very potent, and can reduce cholesterol levels. And that's what's shown in the next slide. So even in FH patients, where we have Nobel-level research discoveries, where we have safe and effective medications available generically, only about half of them are getting the prescription. Documented statins. It's a little higher when you go by self-reports because they know they're supposed to be taking statins and they give a higher response rate. But even worse and even more concerning is that individuals who are eligible for high-dose statins, once they get on statins, they stay at the generic levels, at low-dose levels, and don't get the high dose that's required. Only about 15% of FH patients who need to be on aggressive treatment and high-dose statins actually get it. So the message is very, very consistent. There's a lack of adherence. There's clinical inertia. Even when we prescribe the medication, we don't aggressively go up as required by the guidelines. Sometimes there are wrong incentives. That is not our fault, but we need to talk about it. Those of you who have the opportunity to do editorials, to do education within the policymakers, we need to do that so that the appropriate incentives are given so that most people do the right thing for the patients under our care. Nudges are important. They're being used in many areas. This is behavioral economics, where you make the right thing the easiest choice. And I think there's remarkable work done there, including the Nobel Prize in the last year or two. But we need to find ways to work with our behavioral scientists, our social scientists, our economists to find ways to improve things. So just thinking about what we can do in the biomedical arena alone, it's important, but not good enough. We need to have the partnership with the other sectors that can help make our work a little bit easier, but even more impactful. This is the big challenge, the adverse social, economic, and environmental determinants, the social determinants of health that really impact what we do. And I show this to highlight, again, work done here at Emory. Will Schultz and Arshad and Larry Sperling were part of it, highlighting the importance of socioeconomic status and social determinants, that the really best thing in the future is for us to form the strategic partnerships that place emphasis on our traditional biomedical risk factors that we know about, for which we have safe and effective medications, but also addressing the social and environmental determinants so that we can have the appropriate combined interventions by thinking not just of individuals and their families and where they live, but also thinking what we can do and how we can inform and educate and influence the policymakers at the local and national governmental levels. Of course, what we do in healthcare systems and the types of innovative approaches we can engender and stimulate can make a big difference. I think there is research opportunity to model some of this and find ways in which we can scale up in our communities to make sure that the research work that you're doing really gains traction and impacts large numbers of people. That was the reason why the center I direct was formed 4 years ago. It's a center to advance and serve as a strategic focal point for the NHLBI to advance translation research, but also figure out the implementation challenges, the implementation blocks that makes it impossible for us to address the effective use of statins, the effective use of antihypertensive, the full spectrum of the work we do. How can we make it easier without necessarily impairing the workflow in the outpatient setting or in the clinic setting? This is just to show that we've done fantastic work in bench research. We've actually made significant improvements in the translation from bench to bedside. We've done some remarkable clinical trials that provide us the evidence for guidelines but also for guideline dissemination, for education. I think where we're falling short is in the population-level outcomes research and the strategies that can help accelerate how we move the evidence from research into practice, how we work with the communities to make sure that the people who need our help the most are also getting it. This is one example of some new research opportunities where groups like what you have here at Emory, in partnership with other organizations, with partnership with other institutions within this community, can fully understand the real challenges in the community and why the work you do is not reaching its maximum return of investment. This is going to be funded, we may fund up to 8, for 7 years, doing prototypes of ways to partner collectively in a sustainable fashion to make sure that the research we do has sustainability, has impact, has relevance, and is addressing the real needs of the community. There are several other grant mechanisms that can also be used to address this. Of course, the R21 and the R03 can help in a small fashion set you up, particularly for fellows and early stage investigators, into getting ready and getting the data that will give you your R01. So I think it's a lot easier for us to talk about the molecular biology and talk about the genomic work and talk about the basic science. What I would like to suggest to you is all that is great and we need to continue to support it, but we also have to figure out in your own clinical practices, what are the challenges and how can we put those challenges in a research framework so we can get the support to address that and pilot test how we can make true innovations in our delivery of care to the patients we serve. At the Heart, Lung, and Blood Institute, we've invested substantially in revamping our clinical trial enterprise. And here is the site. If you go to nhlbi.nih.gov, this is the node 83175, and these slides are all going to be available, so you can just hyperlink on it. It shows you the 6 different ways in which we're trying to really stimulate innovative clinical trial research. And of course, we always hope that we have more money that we can put into research. But to be very truthful, given these challenging times, $3 billion is still a lot of money. And we want to make sure that we can get you excited, we can get you stimulated in thinking about these challenges and finding ways in which we can support innovative approaches to addressing the challenges. Training is crucial, and that's why I'm really very proud. I think we have 3 or 4 different T32 programs here at Emory, several other training programs. Your fellowship training program is well-renowned, and I hope, and I would like to suggest that the vascular biology, the basic science, and the early translational work are all very important. But I also want to encourage you, you are very fortunate in having some clinical champions who have seen decades of these challenges, have seen what has worked and what has not worked. I hope you take advantage of that to design some hypothesis-driven strategies for really moving discovery into practice. And that's what we love to support. I hope you also remember when you have the opportunity to engage with students that we have programs for high school and college students, as well as medical and graduate school and postdoctorate. And certainly what we are very, very proud of is our support for early stage investigators and established investigators. But training is a major emphasis for us. It's always good in your research applications to highlight the NHLBI strategic plan. Of course, supporting fundamental research is our core and our first goal. But pathophysiologic work that helps us continue to understand disease and disease processes that can help new drug development and new treatment and prevention strategies, also important. But I've highlighted these last 2, how we bring effective prevention and treatment strategies into practice and make sure that they're sustainable and they really lead to changing some of the data that I showed you, so that individuals who have high-risk coronary disease get not just put on statins, but put on the aggressive and high doses as guideline recommended, and finding ways to sustain a true collaborative and diverse research community through training. What I've tried to share with you is all of you and researchers across the country have good reason to be very proud of the work that's been done. We've had some remarkable discoveries. We made great progress. Cardiovascular science, put next to almost any other field, is just no comparison. So you have very, very good reasons to be very proud of what's been done. These advances have also led to true dramatic declines in coronary disease. I showed you the peak in 1968 to what we have today is more than 70–75% reduction, definitely dramatic improvement. And I think all cardiovascular researchers, including you and your colleagues here at your center, deserve to be very proud. I've also showed you that we have reasons to be concerned, and we have reasons to be alarmed, because these dramatic declines that we've seen in the last 50 to 70 years appear to have stalled and not going the same rate that we've seen in the past. And in fact, when you look at optimal cardiovascular health, not only is it poor for African Americans and Hispanics, but it's getting worse in whites. So in general, it's almost as if we all racing to the bottom. This is something that we can intervene on, something that we can help change. And as part of that process, there's very pervasive health disparities in cardiovascular health and cardiovascular care. And overall, if you look at our life expectancy, it remains poor and significantly poor in comparison to other peer high-income countries. These are the reasons why we have to be concerned, and the reasons why we need to stimulate new strategies that can help us translate our discoveries into practice. But personally, I'm very, very optimistic, and I think we have reasons to be hopeful. We definitely know enough today to eliminate most cardiovascular diseases. I think if we pay enough attention to the social environmental determinants, we think of our role beyond the clinic in educating the general public, in educating and informing policymakers, and testing different strategies that can lead to true innovative ways of translating research into practice, I think we make tremendous progress. And one approach that I've highlighted here is dissemination and implementation research, and that's the reason why NHLBI formed this new center, and I hope all of you will take advantage of it. In particular, we have really outstanding fellows who remain very, very interested in cardiovascular medicine, and I think this is the opportunity to really stimulate that tract. I commend you for what you've done with your training programs, and I hope that you really help them take advantage not just of the extramural program that I mentioned, but also the intramural program at NHLBI. That's all I had, and I want to again thank you for having me here. I try to save some time so you can give me some suggestions that I take back to NIH in terms of what we can do to continue the progress that we've made, but also continue to be optimistic and hopeful that there are ways in which we can address these challenges that I've addressed. So thank you very much for having me.
Thank you. Very nice presentation and being here with us. So my question is, so you thought, no, it's on. Thank you. So, so you have talked about the importance of implementation research and how we move from the results we get in our research to practice, and you talk about some of the RFAs that NHLBI is getting out to promote this kind of research. But in the whole context of what NHLBI funds, this seems a very small piece, and I don't know if there are efforts or if there are ways that NHLBI could promote more of that implementation research in their general programs, you know, in terms of the funding decisions and how things are scored and how things are reviewed. Because what happens, we submit our grants, and then they're going to be scored by study section, which might think that implementation research is important or maybe not. And then if they don't like implementation research because it's not very innovative, or so they don't think it's significant, that's not going to move forward. So has NHLBI thought about how we can, before just not restricting this to just single RFAs, but trying to figure out how it can be something taken into account in the review criteria?
Yeah, a very, very important question. If I may summarize, in essence, the frustration in putting a lot of work, writing applications for implementation research to be seen by study sections as not innovative and not getting funded, sometimes not even reviewed. And what is NHLBI doing to address that? So the first response is, this is exactly the reason why the Center for Translational Research and Implementation Science was formed. We have a heart division that was formed 70 years ago. We have 70 years track record of funding basic clinical and population heart research, not implementation. We've had, since 1976, had a long component that's funded basic clinical and translational research in pulmonary disease, and for 69 for lung disease and 76 for blood diseases. So this is new. The challenge is real. It is NIH-wide, not just NHLBI, but I think the fact that the center was formed shows that we are aware of that challenge and we're doing everything possible. We need to educate ourselves at NIH and our study section members about the importance of this work and the challenge. I think over the next 5 years, you would see significant improvement. I have already seen it. 4 years ago, you go back and look at most documents from NHLBI, there will be no mention of implementation science and implementation research. Right now, the Division of Lung Disease has implementation research as part of its strategic plan. The blood division has that, and our center is helping it. We've already put out our first 2 grants, and in fact, if it's any consolation at all, the last round of institute-solicited applications, the largest funded grant was an implementation science research grant, about 80, 90 million. So please don't be frustrated and never be upset with study sections. Just listen to what they say and resubmit. And we are very, very proud of individuals who continue to resubmit. But we also have other mechanisms where we can reach and select applications that don't make the pay line. We call that select pay. So I would really encourage you. Our director has taken this seriously. In fact, several institutes, NCI, the Fogarty International Center, several others are taking this very, very seriously. So thanks.
George, thank you for the visit, and thank you for your partnership over 2 decades now here with Emory. Great presentation. You really outlined how far we've come, but also why we cannot be satisfied. And this implementation, it's interesting that we still, in 2018, are practicing this episodic and catastrophic healthcare, despite having knowledge in population science, examples globally. And what will it take, because we were on the verge of bundled payments related to tacking on cardiovascular prevention, post-MI, PCI, CABG, and right now the pause button's pressed on that one. But in terms of really investing in communities, this is one of the areas we do poorly in compared to other countries. And so how do we, can you comment on single, I don't want to get too political, but single payer versus, our healthcare system's really complicated. And if I was talking to one of our trainees last week, I said, if we were to start all over again, just take a board and erase it, and then say, what are we trying to accomplish? You know, I mean, that the patient and the family and the communities really need to be in the center. So how do we bridge these challenges? Because we have great opportunities, but in our country, more challenges than any.
Yeah. Very important question. I think you've actually summarized it well. So your question provides an inherent answer in itself. What we are doing, though, is recognizing that challenge. So our National Council has actually approved an institute solicitation that I can't talk about the details, but I can assure you that community-engaged, community participatory research that addresses these challenges in terms of finding new ways, that's just about to hit the street. So in fact, right now, this morning, the Division of Extramural Research Activities is meeting with my center leadership, addressing that specific initiative that will come out. But it's a drop in the bucket, but I think it's a start. So the continued emphasis on health policy and how that health policy impacts care and how new strategies need to be tried, I view them as scientific questions. I think for a long time, NIH viewed its work as the basic science, the molecular science. It was somebody else's responsibility to take these wonderful discoveries and make something happen, right? But that is changing. It's a full continuum, and that's the cartoon I showed you, going from fundamental discovery to population-level outcomes research, with a special emphasis on the community and the patient and the family. So I hope that many of you would keep your eyes open for that initiative. It's called Decipher. So when it comes out, it's a tie-in to community-engaged, community participatory research with a focus on high-burden communities, so that not only do we make a difference in improving cardiovascular health and lung health, but we can make a difference in addressing disparities. So hopefully we get many, many more of this. And it's going to require true partnerships, not just the academic research lab, but really the academic research lab, the expert clinicians who have seen these challenges, the community leadership who knows what the community needs are, so that a formal needs assessment is done to drive the hypothesis that needs to be tested and the strategies to be tested. I'm very, very optimistic about it.
Another part of this overall problem is we're going to have to address our excesses. We spend more, do twice as many MRIs, scans, defibrillators, pacemakers compared to other Western countries with no better or in fact inferior results. So why is that? Is it in the profession, do we need better clinical skills? Do we need tort reform? But messages are hard to get across. I will give a personal story of many years ago. I was writing and interested particularly in syncope, and I wrote about that and with a physician at Virginia about how to work up syncope. And it never took. And it still doesn't. I recently saw a friend that had a typical orthostatic dehydration passing out. And when you see the array of tests that have been ordered, it's embarrassing. And that's away from a bit from what you're talking about in your mission, but it's in the equation.
Actually, you'll be pleased to know that I don't consider it different from what I talked about. Within the context of implementation research, there is a component of de-implementation, which is where we have compelling evidence that something shouldn't be done, and we're still doing it. You shared your personal story. Let me share a very brief personal story. And I know this never happens at Emory. I'm just only mentioning it as an example. During our cardiology training, and even during internal medicine residency at Cornell, one of the first things every good intern knew to do was when a patient was admitted to your service for rule-out MI, they got 6 inches of nitro paste and they got nasal oxygen blowing up their face because we knew the oxygen was good. Whether they had an MI or not, it was good for them. And everybody had nasal oxygen. In fact, the rooms were arranged that it was automatic. The nasal oxygen cannula was there. You just put it on, and most of the time it wasn't actually in the nasal cannula. It was somewhere on the face. There's compelling evidence that we actually do some harm in the routine administration of oxygen, but it is not cheap either, and we continue to do it. There have been at least 3 randomized trials that have shown that there is no benefit in routine administration of oxygen, yet we do it, and it's part of the cost. And so what de-implementation science is first doing the evidence synthesis and integration or rigorous systematic review and finding where there are randomized controlled trials saying something shouldn't be done, and we find ways to de-implement it. So what you've talked about is really part and parcel of the same piece. And in fact, many people argue that one of the best ways to get the resources to do the good stuff we want to do is to stop doing the useless stuff that costs money and actually may cause harm. I mean, the National Academy of Medicine has shown this very clearly, that harm reduction is key and is part of the implementation. I'd be happy to send you a perspective that we've written on de-implementation science and how it should feature into implementation research. Yes, ma'am.
So I appreciated what you said about, I guess I could also share a personal story, which is about research and not about, thinking about patients. But what you're proposing in terms of implementation science and communities that are highly burdened takes a really long time. And so to piggyback on Auro's point, if you go through the regular funding mechanism, it's impossible to do that in 4 years. It's incredibly, incredibly difficult just to enroll populations from the community, much less do CBPR work and partner in implementation science. And even if you go with the early stage investigators who get 5 years, it takes them even longer from a career perspective to get results from that type of study that would then build their careers. So I'm just wondering how NHLBI is thinking about this, and thinking about rolling it out and making it more a part of the larger portfolio. I appreciate that there are 7-year grants because I do think that's what it would take, but I don't think that that necessarily would work for an early stage investigator's career. And I think going through regular channels with the 4-year cutoff will be really tough for established investigators.
Yeah. I'm not sure that people in remote sites always get the question, so if I may paraphrase very briefly. Doing research that we've described as implementation research, especially in high-burden communities, is challenging. And taking the same traditional approach of 4-year funding or even 5-year funding, it's not going to do it to execute and get results. So how is NHLBI addressing that challenge? Again, it's a very well-recognized challenge. I tend to be a bit more optimistic. I think we're making progress even in thinking about it. This is the first time that we've given 2 years for a planning phase. So, and then a total of 7 years to be able to do it. Traditionally, we give a 1-year milestone for clinical trials, and then you go on for 5 years. So we recognize that this is difficult work. It's also not cheap. Sometimes the notion is if it's implementation research in the community, you can do it with less funding than what you do in a basic R01. And that's been recognized by the Institute as incorrect. So the good news is we recognize the importance of a longer duration, especially a longer duration of planning, even building the partnerships in the community and figuring out what the community needs are and what the community prioritizes so that you have community buy-in. That takes time. And we are very willing to recognize that and pay for that and be as supportive as possible. Obviously, I doubt very much that the Institute would support a 10-year grant, but I think if we can demonstrate with evidence that even 7 years is not enough, we happen to have an Institute leadership that is very, very responsive to investigator request and demand, and we would find a way to respond. I think the essential message is a truly upbeat message, that we know that our basic science has been supported for a long time, and we need to continue to support that because without fundamental discoveries, you wouldn't have any scientific evidence to translate and implement. But we also have to support the other end and find ways to support particularly clinician scientists in the community, because what we really need now is practice-based evidence. What has been shown in practice to work, rather than what's been rigorously designed as a randomized controlled trial and then try to fit it on into the community. And we need your help, and we need your suggestions as to what else the Institute can consider, what other approaches we can do to make this work.
I think it's time. Thank you very much, George.
The preceding program is copyrighted by Emory University.